I am just thrilled and delighted because I think it's a real privilege for me to have this opportunity to speak with you this afternoon. I also want to express my sincere gratitude to Catherine, to Josh, to Dan, to Keith, Gisette, and the entire planning committee for giving me this opportunity and for including NIH on this program. They took a little bit of a risk, though, I should say. On Friday afternoon, I had to send them an email saying, I'm very sorry, but I cannot attend if there is a shutdown. And so trying not to be completely disappointed, I offered that I would record my presentation on Saturday. If there's a government shutdown, I will not be doing any work on it on Sunday. I would already record it on Saturday, and I can submit it so it will be presented. But I had to get approval. And the message I got back was the simple one line, no, not allowed. So I was really just delighted that on Sunday that government was in business and I was able to come. So thank you very much for having me. On a very personal level, though, and also on behalf of the National Heart, Lung, and Blood Institute, I can't tell you how thrilled I am with the name change and the expansion of the mission of the Family Heart Foundation to include LP(a) in your work. So congratulations on that. And this has already been an outstanding summit. Really enjoyed yesterday, really enjoyed the presentations today, and particularly the patients' stories. It really reminds all of us why we went into this business. Now, in your program, I'm supposed to talk about the NHLBI Decipher program. But after I met with Keith and Gisette, I decided, sure, I'll talk about that, but I have 6 slides on those. And the rest of it, I really want to use the opportunity to center the huge challenge of health equity and how we make advances in health equity. And especially learning from the keynote yesterday, what have we been doing that has led to this failure to close the gap? What else can we do? Who else should be involved? And what types of research should you encourage the FH Foundation to support and also the NIH and NHLBI to support? So the title that I have here, Advancing Health Equity in the US, with a direct response from what I learned on day 1, is yes, we need wider lenses. But like every professional photographer would tell you, you don't just go around with one lens. We need multiple wider lenses. And that's the message I'll try to convey. The advantage of being one of the last speakers is that a lot of the things you intended to say have already been said. So I will go pretty fast on some of these slides. I've also hidden some slides, but the entire slide set that I put together on Saturday will be available to you. So don't be upset if I go over and not discuss a particular slide. Here's my disclosure. I have no conflicts. And especially since I'm going to be talking about something that we're not very proud of, I thought I'll use data and evidence from the federal government, because I don't want anyone to feel like I use your research to highlight a major failure that we've had. And so here we go. You are all familiar with the Heckler report. This Margaret Heckler was the secretary for the Department of Health and Human Services. And back in 1985, she put together a task force. Actually, the task force was put together in 1984, and they presented their results in 1985. The reason for the task force being put together was that in 1984, the CDC published its annual Health US. That showed a horrible state of affairs when it came to health disparities. And Margaret Heckler said, we have to do something about it. And as you can see on the right side of the slide, this wonderful report that looks great on any shelf in any library was put out, extensive report about the many different things that we can do to address disparities. So let's ask what happened. That was 1985, 30 years later. So this is the 30th anniversary assessment of the Heckler report. And I'm showing you the results for trends and disparities for 6 of the most important conditions that were prioritized in the Heckler report: care for cancer, care for heart disease and stroke, cardiovascular diseases, substance use, diabetes, suicide, infant mortality, and maternal care. The first column that shows the trends really shows just a mixed picture. Some things were improving, some things were getting worse, and some things remained unchanged. I want to point your attention to the most recent disparities that were found around 2015, the time of the analysis. For cancer, disparities were 50% worse than when the Heckler report was presented to Congress. For cardiovascular disease, it was 33% worse. For substance use, no change in the disparities. Care for diabetes was 78% worse, and you see the rest. And I highlighted the last column in red because that was where they tried to answer the question, what was the disparity change? And as you can see, for cancer care, disparities were narrowing by 67%, same for care for diabetes, but for the rest of the priorities, absolutely no change. Now, you might say, these are data from 2015. Of course, we've got to be doing better. This is 2023. Well, we have data from 2022. Again, using federal government data, but all of you are familiar with other data that shows that, yes, we've made remarkable progress when it comes to cardiovascular disease, but we have really failed in terms of closing the gap of the disparities. And all I want to show with this chart is using a different system. This is the Healthy People, and you know we started Healthy People 2000, Healthy People 2010, Healthy People 2020, and the question was, if you look at all the objective measures in Healthy People 2020 and ask the question, did disparities narrow? Did disparities increase or worsen, or was no change? And the very first part of that graph on the right, the dark color represents disparities that were narrowing, meaning improving. And as you see, only about 4 to 14% of the objective metrics showed any improvement. The far right of that chart, you see disparities that were worsening. It was about 3.8 to about 8.9, around 6 or 7% worsening. But the vast majority of objective metrics we had for Healthy People 2020, about 76 to 92% of the time, absolutely little or no detectable change. We cannot continue to do things the way we've been doing for the last 30 years because we get the same results. So the question is, what else do we need to do? Who else needs to be engaged in this effort? And when you think of research, what different types of research should we be supporting you to do so that we can get better results? I really want to use the rest of the time to talk about why we need multiple wider lenses in health equity, so we can see beyond what all of those hard workers in the past were not able to see and were not able to influence so that we could have gotten different results. First, there's really more to health inequities than just black-white differences. The Heckler report was black and minority health, and all the data were black-white comparisons, Hispanic-white comparisons, and other race-ethnic group comparisons. We know that even within the black group, the African Americans, there are huge disparities by education, by income, by geography, even by zip code, as we heard yesterday. Same when we think of Hispanic and the Latino community. We know that there are very big differences between Mexican Americans and Cuban Americans and Puerto Ricans. And so the notion that we can look at black-white differences and design studies that target race and ethnicity, that's something that should be gone. We have to have a wider lens and include, in addition, the social environmental determinants that can help us make better progress. Within the American Indian, Alaska Native, Native Hawaiian, and the Pacific Islander population, very often we don't even report the data. And the explanation is too small sample sizes, we're not confident with what we saw, but truthfully, we can do better than that. There are tremendous disparities that we need to make manifest and come up with strategies that would address them. And even most importantly, we rarely explore the intersections between all of these different factors. African-American women or Hispanic women who have less than a high school education. It's a completely different story, and we need to look deeper and we need to plan better so that we can make significant differences. This is one slide to highlight the huge disparities that we see within any one particular group once we start paying attention to educational attainment. This first chart shows you the differences. I should first mention that the 3 blocks represent data for the total population, the middle is for men, and then to the right is for women. And each of the 4 bars, the first bar represents the disparity we see when you look at the difference between those with a master's degree or higher degree compared to those who did not complete high school. Huge difference. On average, around 15 years difference in life expectancy. It's about 16 in men and about 14 in women. When you look at poverty, similar story, although not as deep as you see in education, but the trend is very, very consistent. And to the right, I'm showing you a graph that's a summary measure of socioeconomic advantage or disadvantage. So socioeconomic disadvantage is in blue, and almost every category you look at, whether you're looking at the total population or you're looking at men under the age of 45 or women of that similar age, it's about a 10 to 15-year difference. And so these factors are extremely important. The time for designing studies that just look at black-white differences or race ethnicity differences without paying attention, meaning having a much wider lens that gives you a much bigger picture, that those times have come and gone. This is a cartoon I found on the web that I find very, very helpful. And it defines an equity lens as a pair of glasses that helps us see things from a new perspective and helps us to become more effective in our everyday work by getting a clearer focus and a more complete view of equity and inclusion. Just a short personal story. Lenses are extremely important. That was one reason I was very, very fascinated with this meeting and the major theme that you picked for the summit. I recently had a change in my vision that's given me a real challenge. I can't see distance, and my progressive lenses don't help. I can see very close by, so previously I couldn't look at my laptop and work on the laptop without my glasses. But now I don't need the glasses to see the laptop, but I can't see that screen down there. So we had to jiggle up this combination of laptop and try to synchronize it. So that's the reason why I'm using this laptop, but at least I can see the laptop and hopefully be able to give this presentation. Another theme that's extremely important to consider is having a very explicit anti-racist approach in everything we do. It's almost another lens you carry with you together with the equity lens. And Rachel Shelton has this wonderful paper that goes through actually how, when you think of implementation science, as you heard in the previous session, whether it's stakeholder engagement or thinking about the different theories, models, and frameworks that we use, or even your whole evaluation process, we need to have an anti-racist stance and make sure that we're doing things the right way. It's a very nice paper that actually goes through what are specific examples of anti-racist approaches in the study design, picking implementation frameworks, and doing evaluation for impact so that we can get to health equity. American Heart Association, Family Heart Foundation, most professional societies now recognize that social determinants of health are crucial. Whether it's education and access and quality of that education, or even healthcare access and quality. We all know the value of neighborhood and built environment and the impact they can have on risk factors in cardiovascular diseases, social and community context. All of these, together with a notion of economic empowerment, whether there's joblessness or not, and economic opportunities, all of these add to findings of disparities. So we really can't look at just black-white differences anymore. Here are a few examples of concrete things that we should do. And at NIH, we are thrilled when you take these into account in the applications that you submit for work, at least from my center. Here is two things you absolutely have to keep in mind. The core principles of community engagement must be first and foremost in any studies thinking about how to advance health equity. The National Academy of Medicine's conceptual framework on the right that you're familiar with, I think paired with the core principles of community engagement can make a huge difference and really help us make progress where we have failed. The conceptual model really puts communities and community engagement as the core of what we do. And then think of how we co-create, how we come up with strategies that are meaningful to the community that leads to communities thriving and build community resilience. It's absolutely critical that we use wider lenses that incorporate meaningful community engagement in our work. I should have mentioned that the third edition of the core principles of community engagement should be coming out later this year. It's funded by NIH and CDC and other federal government agencies, so it's entirely free. And I strongly encourage you, if you're thinking of any community-related work to be funded at NIH, or for that matter, CDC, really think about this document and make sure you're familiar with it. Now, this is what I was actually asked to talk about. Now, I'm very grateful Dr. Daphne already gave the section on Decipher in Louisiana. So I'm just going to show you 6 slides very, very briefly, but within the slide deck that you will receive as a handout is more information and additional slides that I'm not going to show here. But the Decipher program, Decipher stands for Disparities Elimination through Coordinated Interventions to Prevent Heart and Lung Disease Risk. And the whole notion was, at NHLBI, we've been funding research for more than 75 years. In fact, next year, we're going to celebrate our 75th anniversary. We hope all of you would join us to cherish some of the remarkable work that you have been able to do through funding that we've provided. But we are very proud of the Decipher program because it was the first time we asked the question, how can we take the discoveries we funded in NHLBI and turn them into real-world impact through active community engagement? This is a map that shows you the programs we funded across the country. It goes all the way from the West Coast to the East Coast. We cover part of the Southwest and a little bit of Mid-America. But there are 7 funded research centers and a coordinating center at the UNC in Chapel Hill. And what I will do is just give you a brief sense of what selected examples of what these programs are doing and how what you've talked about these last 2 days really reflect much of what they're trying to do in their own communities so that we can make a difference and get different results by the time the work is completed than we saw after 30 years of the Heckler Report or what we saw after Healthy People 2020. So in the Decipher program in California, Arlene Brown and her colleagues are working with the Los Angeles County Department of Health Services clinics. I understand the second largest safety net system in the US. And what they're doing and focusing on is really going beyond just black-white differences. They have a large Asian population. They're looking at Filipino Americans. They're looking at Korean Americans, looking at Chinese Americans, and asking the question, what strategies would really lead to effective adoption of the strategies we have for controlling blood pressure and cardiovascular disease? Most importantly, taking advantage of safety net healthcare settings in order to address the community engagement, strategic partnership building, addressing social risk, and looking at real-world feasibility of this work. To the right is how they've mapped out the year, and I'm showing this only as an example because I'm sure someone would ask a question, what types of research would you want to support at the NHLBI? It's a very, very good example, and all the Decipher programs have similarly outstanding approaches. In Colorado, for example, Stan Scheffler and his colleagues are looking at asthma disparities in schools and looking in particular at the educational disparities, looking at some of the rural-urban differences they see, and the opportunity to have better linkages between children and families. Oh, I'm sorry, I realized that that's not the right slide. Here is the Colorado study. But everything I said, you will see on the slide there. But they're really working very hard at building partnerships among children and their families, the schools, bringing in school nurses, bringing in navigators, bringing in different community resources that previously might not have been thought of as being very helpful to preventing asthma in schools, like school bus drivers, who very often can tell when a kid has symptoms compared to previous days when they don't. But this is an excellent example of a comprehensive approach using multiple lenses on a community to be able to address disparities. Maryland and Michigan are partnering, looking at people with severe mental health challenges and how to test the different strategies that can lead to effective delivery of care that they need. To help mental health professionals give this ideal care, they have specific goals and studies that would test the 3 different programs that I've listed at the bottom, replicating effective programs that have been shown to work in other areas and testing them within Maryland and Michigan, providing provider coaching, and also organizational facilitation. But the important concept is paying attention to multiple facets that is consistent with the notion of using multiple lenses and wider lenses to address these challenges. There are actually 2 different Decipher programs in the state of Illinois. One at Northwestern, and that's looking at blood pressure, as you see in the diagram there. They're using the Kaiser bundle that many of you are familiar with. The Kaiser program, to the best of my knowledge, was the first to demonstrate in the healthcare system that not only achieved greater than 80% blood pressure control, but also eliminated disparities in their population. And the question is, can you do this in the south side of Chicago, where there's a huge burden of hypertension, hypertension-related stroke, heart failure, ischemic heart disease? Again, everything we've heard in the last 2 days, but putting it within the bigger concept of, I am very personally sure that we are going to make progress. Listening to the science that we've heard here, when it comes to quality of care, what I'm not sure of is eliminating and closing the gap, and that's where we have to pay attention. The second Decipher program in Chicago is at the University of Illinois in Chicago, and again, they're focusing on a major risk factor that actually overlaps cardiovascular diseases as well as chronic lung diseases, tobacco use, and poor access to tobacco quit programs. You're looking at low-income communities race and ethnicity are important, but they also look at the social determinants of health, safety net, health center access, and how to use proven interventions within these communities to be able to demonstrate impact. The CTRIS program, you already heard from Dr. Daphne. Again, we're very, very proud of this program. It's using a church-based approach where the leadership is not the cardiologist. You forget Dr. Ferdinand or Mr. Ferdinand. The real key here, people really doing the work, and I think Keith meant it when he said, if it wasn't for Chloe, maybe he would still not be doing this work. But how do we design programs that empower community health workers to really lead to results that may be a little different that we've seen in years? And that's what we're expecting from the Louisiana program. So CTRIS, we're very, very proud of. Again, church-based social determinants of health, multifaceted, looking at multiple different aspects from the community perspectives, and addressing issues of effectiveness, implementation, and sustainability. And again, this is a coordinating center that provides support for all the centers. Nothing very different, very similar to other coordinating centers that you have. So let me close with a few comments on how collectively we can chart a future that can be described as not only improved quality and the best care for cardiovascular disease, but also improved quality that comes with closing the gap in the huge disparities that we see. I meant what I said about what we think at NHLBI, and personally, how proud we are that the mission of the Family Heart Foundation has been expanded to include lipoprotein little a. But in addition, the support for research that you do, we know we can't boil the ocean. We can fund all research that needs to be done. So every little bit that everyone does helps. And I think the registry work and the information and the science that you've produced is another excellent example. This work was 7 years ago. I'm looking forward to seeing the follow-up that tells us what's happened to the disparities, what can we learn from the work, and how can we begin to feed in LP little a into this work so that we can really make progress. I think some of the science that you've surfaced around the importance of thinking about women, the unique conditions that women go through that impact their care and lipid management, really crucial. We all should know and be able to find ways to eliminate this disparity. Women who are 34% less likely to receive any statin therapy. And it's even worse when you think of high-intensity statins. And when you look at target LDL, worse in women than in men. So we have a lot of work to do. Asian and black persons also 30 to 50% less likely than whites to achieve adequate LDL-C. My message is we need to do less describing these disparities. We need to actually do something about the disparities and close the gap. And from an NHLBI perspective, nothing would please me more than to see an application that is not talking about the huge disparities we have, but concrete steps with meaningful engagement of communities, with implementation strategies that can really point us the right way to make progress. It's sad but true that there are, even today, some communities where there have been no studies in FH. This is one of the findings from McCollum's systematic review. And you see Canada, US, Australia, and yet not a single study that mentioned or had data on the prevalence of hypercholesterolemia. This just makes the point that we still have a lot of work to do. And there are areas where we haven't studied, we don't even know the burden and the prevalence of familial hypercholesterolemia, not even to mention what we could find about LP(a) in the community. So we have a lot of work to do. Let me go to my very last slide, and again, really very proud of the changes you've made. When I read Brandt's paper, I must admit I didn't recall anyone pointing something like this out to me in medical school. But from this assessment, we know that women have slightly higher median Lp(a) than men. There are several other disparities that I mentioned, but you see the median for non-Hispanic blacks really stands out. And the question is, what are we going to do given everything we've learned over these last 2 days in the summit? So I'll conclude by sharing with you, we definitely need wider lenses so we can see more, can see better. We need multiple lenses, and clearly we need to go beyond black-white differences or Hispanic-white differences. All of us should have genuine equity lenses and anti-racism lenses in everything we do. Sometimes it's just a minor tweak, but being explicit and putting on that lens, we can do better. The real importance of social and environmental determinants of health, they should really be used to inform design of our research and the assessment and evaluation of our research. Fortunately, there are equity implementation frameworks that have been developed. At least I'm aware of 3. So if you're thinking of an implementation framework, it's just as easy to think of where an implementation equity framework exists to be able to use that. And then finally, let's do our best to assure that the core principles of community engagement are part and parcel of our work, and let's apply the 4 key lenses of community health systems for policy, for practice, and for research. And I think I'm going to stop here and thank you very much for this opportunity.